Well, welcome everyone. And hey, listen, thank you very much for showing up on nearly the last session on the last day. I'm pleased that it's more than just Chris and I talking with each other. That's a number of you showed up. I had low expectations because I appreciate particularly people on the East Coast are already getting on their flights and heading home. But it's wonderful to have a group of you here that are interested in this topic that we're presenting towards the end of the session on chronic overlapping pain conditions. And we took a little editorial liberties with the title of this, and we added in, think of it as a bonus session on high impact chronic pain. And the reason for this is that these two concepts, chronic overlapping pain conditions and high impact chronic pain, are both incredibly topical. They're important, and for those of you who are clinicians, each of you are going to be seeing more and more of this as we go forward. Before getting going, why don't we do our introductions? And Chris, why don't you take it away?
Sure. I'm Chris Feasley. I'm the co-founder and director of the Chronic Pain Research Alliance. We're a small grassroots advocacy initiative that's really working to advance both the overall federal investment for chronic pain research as well as research on chronic overlapping pain conditions. We also work in the knowledge translation space, so trying to make sure that as new research findings on COPs come out, we're getting it into the hands of patients and clinicians right away and not 2 decades later. And then we also work kind of in the area of advancing therapeutics and models of care for overlapping conditions. I myself have had chronic pain and a number of these conditions for 30 years. So I also kind of come to the table with a research background as well as the patient perspective.
Chris is wicked smart, and she has got an incredible insight into the intersection between science, policy, and the human condition that is of incredible value. So we've been fortunate to be able to collaborate with Chris, with her organization. We're going to show you some resources later, but you see her website, cpralliance.org, the Chronic Pain Research Alliance. It's a wealth of information. I'm Sean Mackey. I'm a professor and chief of the division of pain medicine at Stanford University, where I've been for somewhat over 25 years there, including my training. I'm a physician scientist, and I still take care of patients a couple days a month at this rate, and much of the rest of it doing research. A couple broad areas, I've presented on some of that here, in the area of neurosciences related to pain, and then also in outcomes. And in both of those large buckets, it overlaps strongly with the concepts that we're going to discuss today, which is that of chronic overlapping pain conditions and high impact chronic pain. I think you're going to hear Chris use the acronym COPs, and I sometimes fall back on COPC. It's the same thing if you hear us throw that out. It's chronic overlapping pain conditions. So let me start with the punchline for this, the why. Why are we here? Why is this of importance? And I'm going to fall back on this rather old Indian parable of the 6 blind men and the elephant. You've all seen it. The blind men feeling different parts of the elephant and calling out what they think it is. And this is a metaphor, if you will, for healthcare in general, the isolated aspect, the siloed aspect of how we often perceive people's conditions. And never more true than that in chronic pain, where we tend to focus on that most impactful condition that the person is presenting with, whether it be low back pain or headache or neck pain or GI symptoms. And the take-home message that we're going to be getting to and building to this punchline is we really need to look at the person as an entire person and from a patient-centered view, and recognize that the vast majority of people who show up with chronic pain conditions indeed show up with more than one. And we'll show you some data on that. The second part of this around high impact chronic pain pulls a lot of this together, because as we'll build a case, those with chronic overlapping pain conditions also will experience this thing we call high impact chronic pain. Why is that important? Because if we're going to get to the holy grail of precision pain medicine, which means the right treatment for the right person, the right circumstance, we're going to need to be able to appropriately risk and treatment stratify them. And in the context of high impact chronic pain and chronic overlapping pain conditions, we are probably going to need very specific treatment pathways that we can identify the right person and put them into that pathway to lead them to a successful outcome. So that's the punchline. Let's go build the story. And Chris and I just met for breakfast a little bit ago to kind of decide how we were going to do this. And we decided we're both just going to stand up at the podium and we're just going to pass the baton back and forth. And I'm pretty sure you're leading us off.
Thank you, Sean. So I'm the former executive director of the National Vulvodynia Association. And just to give you a little history on kind of how COPEs came about, back in around 2007, 2008, individual leaders of all of our organizations, the TMJ Association, the National Fibromyalgia Association, so on and so forth, started talking about this group of patients that we all communicated with that seemed to have multiple conditions. And at that point in time, there wasn't a lot of research that was being done looking at what is the coexistence of pain conditions, right? And if you talk to a lot of clinicians, they would say, yeah, the majority of people have, 75%, whatever, would have just one isolated pain disorder. And then you have the smaller cluster of people who kind of have everything. They've got fatigue and they've got mood disorders and sleep disorders and multiple conditions. Well, the NIH then started funding a couple of very large scale studies looking at kind of the overlap or coexistence of these conditions. And we also started engaging with patients to find out, is that really the case? And it actually turned out, particularly in women, that it was the opposite, right? That women actually more oftentimes than not have multiple pain conditions. It's just that they were going to maybe an orofacial pain specialist for their TMD or orofacial pain, and they were going to a gynecologist for their vulvodynia, and neither one of them was asking about the other, right? And then they maybe were seeing somebody else for their mood condition and somebody else for sleep disorder, and there was no kind of integrated care, for these patients. And so we got together and we said, well, what's the difference, right? Is there a difference between somebody who has an isolated kind of knee OA versus somebody who's going on to have multiple sites of body pain and non-pain comorbidities? And there really wasn't a scientific focus at that point in time to look at kind of these conditions from a multi-system complex illness approach or a systems biology approach. And that's why we formed the CPRA, really to focus in that area. And so around 2013, we started working with the NIH. That's when they kind of coined or defined the term chronic overlapping pain conditions. We admit it's probably not the best word or term, and we may come up with a new one in the future, but for now it was kind of what stuck in terms of trying to describe the clinical phenomenon of COPEs, right? So COPEs describe conditions that often coexist and share similar disease mechanisms, mainly across the neurologic, immunologic, and endocrine system. Many of these conditions either solely or predominantly affect women. Any number of conditions is possible, or a combination of conditions. They can develop very, shortly together, like cluster together, or some people develop them slowly over time. And a lot of people say, well, is this the exhaustive list? And I would say absolutely not. As research continues, we even know for some people who develop osteoarthritis that they kind of fall into this more centralized type of pattern where they have other conditions, whereas other people don't. So as research advances, this certainly will not be the end list, I think, of conditions. And probably there are subgroups or phenotypes of all of these patients that fit more in the COPEs phenomenon than they do, in maybe another mechanistic area. And what research has really shown over the last 10 years, in my opinion, is to really highlighted the complexity of chronic pain. America has become a nation of chronic illness. Over 40% of Americans live with 2 or more chronic conditions, right? Including chronic pain. And then, as Sean just mentioned, a lot of times people present with multiple pain conditions. So now you have multiple chronic illnesses, multiple sites of body pain. On top of that, those people are also more likely to have non-pain comorbidities like sleep disorders, mood disorders, cognitive dysfunction. And then based upon each of our individualized biopsychosocial, spiritual makeup and experience, we experience pain in a very highly complex way. This has been a major shift from the patient-centered perspective, from thinking that pain is like this one little isolated thing that happens in your elbow, right, to really understanding the complexity of chronic pain, the multiple body systems that it affects, the bidirectional impact of those, and how people as individuals experience pain. So this is one of the studies that I mentioned earlier that the NIH has funded, and Sean has been involved with the MAP study. This was led by NIDDK. I think it's still ongoing, right? Yeah. So this was a prominent longitudinal interstitial cystitis study. And one of the things that they looked at in this study was comorbidity as a disease modifier. So out of around 400 participants, 38% of them reported at least one comorbid pain syndrome, and 44% female, 31% male. And if you look at the co-prevalence rates, you can see around 8% had ME/CFS, about 9% had fibromyalgia, 57% irritable bowel syndrome, but 25% of those had more than one diagnosis, right? And in that population, you can see that they had more severe bladder symptoms, they had greater pain severity and interference, they had increased depression, anxiety, and stress, and they had increased disability and decreased quality of life. So as the number of conditions increases in a person, or the sites of body pain, you have kind of this negative sequelae that happens. And that led them to come up with two constructs, which you can see on the bottom of the slide, that are associated with comorbidity. One they call generalized sensory sensitivity, where people who had more than one comorbid condition had increased sensitivity to external stimuli across multiple sensory modalities. They had increased sensitivity to internal symptoms and sensations, mainly what we call somatic awareness. And then they also had increased hyperalgesia and allodynia in multiple areas of their body. And they also came up with the construct space, which shows that in this population, they had more sleep disturbance, more widespread pain, more negative affect, cognitive dysfunction, and energy depletion and fatigue. The other study that the NIH funded, and by the way, between these two studies represents, I think, upwards of $250 million investment from the NIH, which is, again, the first time that they've ever really funded studies like this to look at the phenomenon of coexistence or comorbidity. This was the OPERA study that was led by Dr. Bill Maxner, and this was mainly looking at a TMD cohort. And they also assessed comorbidity as an important disease modifier. So they did a cluster analysis of around 1,000 chronic TMD cases, and they compared them to around 3,000 TMD-free controls. And what they found is that people clustered into one of these three groups. The first one was called adaptive, where people in this group they had relatively normal psychosocial and autonomic profiles, normal muscle sensitivity. There were more men than women in this group, very few TMD cases. Of those that did have chronic TMD, they were very moderately asymptomatic, very few overlapping conditions, and very few negative life events. The second cluster, which they called pain sensitive, was kind of in between 1 and 3, but the 3 is where you would see a lot of chronic overlapping conditions, and they term this one global symptoms. So in this category, people had abnormal psychosocial, sensory function, and autonomic profiles. Many more women in this group than men. They tended to be a bit older. Many chronic TMD cases, and of the TMD cases were very symptomatic. Lots of overlapping conditions and many negative life events. And so we know from a lot of research at this point in time that when the number of body sites of pain or increase of diagnosis increases, you have, as we've seen from the last two slides of these two studies, you have worsening of both localized and systemic symptoms. And importantly, this patient population then has decreased treatment effectiveness. And that becomes very obviously important when you're clinically managing this case. It doesn't matter if it's a pharmacologic or non-pharmacologic intervention that you're using, they're going to be less responsive to it. There are reduced health and psychosocial outcomes, increased disability, increased costs, both personal and societal, and markedly diminished quality of life. And that's of no surprise, right? You would imagine the more conditions you have, the greater non-pain conditions you have, sleep, mood disorder, so on and so forth, the less joyful and, what's the right word, the more impactful this condition becomes, which ties into what Sean was talking about with high impact chronic pain. There's also the second kind of vicious cycle that happens, which we saw from the MAP study and their space construct, right, where as the number of pain conditions and COPEs increases, you have sleep problems and mood problems, which then compounds your energy and fatigue issues and decreases your activity, which leads to more pain, and the cycle just kind of keeps continuing. And this really highlights the need clinically to not just look at pain, even if you're looking at it in multiple systems, but looking at the non-pain comorbidities that people experience with these disorders.
So building on this a bit, we've done some studies at Stanford using our learning healthcare system, Choir, to characterize large numbers of patients that come into a tertiary care referral center. This was a study involving many thousands of patients who came in with a primary complaint of headache or migraine. And as I'll show you a little bit later, using a body map representation, and I'll dive into that, as I said, in more detail, what we found is that of those who came in with a primary complaint of headache, only 29% of them had isolated migraine. The other 71%, over 70% of these patients had more than one chronic condition. And we think this is representative of what you're seeing in your population. You know, in the prior slides with the map, you saw a much smaller percentage of people that had the chronic overlapping pain condition. And having been involved with that, in part, that lower number was represented by many of the sites were recruiting from urologists, and they were excluding people who had multiple chronic conditions. And so much of those chronic overlapping pain conditions that came in through the map actually came in through the tertiary referral centers. And we think that this is more representative of what is going on out there. Now, what we also found is that the more pain conditions people had and the more body sites that people had, the worse they were in physical, psychological, and social functioning. Interestingly, we also found that those who had higher numbers of body map areas also were much more likely to have had adverse child events. And so we don't know whether there's a causal connection there, but it certainly is intriguing and one that we and others are exploring. Getting back to the map, diving in a little bit more from a mechanism standpoint, this was a study led by Jason Kutch that brought 5 of the map centers together that did brain imaging. And what we did is we pulled data and we investigated those patients who had either isolated pain or who had multiple pain conditions or chronic overlapping or widespread pain. And what we found is the following, that 75% of those with chronic pain also reported pain outside the pelvis in this particular cohort. This is a subselection of the map. And in addition, we found very specific regions of frontoparietal networks that were more likely associated with chronic overlapping pain conditions. In other words, there was networking issues in the brain that seemed to correlate well with the number of body map areas that people represented. Those who had more widespread pain, as you might expect, had poor psychosocial functioning and overall worsening global health.
Yeah, so these next 2 slides are really just showing kind of the differences between the different types of pain, right, and where COPEs fit. So you can see that in the centralized, or what the ISP has now renamed as nociplastic, it's largely believed that COPEs are resulting from the CNS or a systemic problem rather than something that's happening in the periphery, such as inflammation or tissue damage. The pain is widespread and accompanied, as we just talked about, by fatigue, sleep, memory, and mood issues. And then the treatments are really geared more towards the central nervous system versus something like on the left side of the table, which is a more classic example of an osteoarthritis or an autoimmune condition. And this is a slide from Bill Maxner's opera study, really just showing the complexity again of what COPEs are. So on the left side, you can see that genetic variability combined with environmental exposures increases the chances that a person will result in having a persistent chronic overlapping pain condition. And then on the bottom of the slide, you can see that these are all complex domains from the immune, endocrine, and neurologic system that can combine in any type of way to both increase levels of emotional distress, and levels of pain amplification. And the more of those that you have, again, you go up to the top triangle, moving you from some clinical signs and symptoms of an overlapping condition to having a persistent pain disorder.
So how are we going about operationalizing this as we move forward? And how can we translate some of this research knowledge into picking up people with chronic overlapping pain conditions in our clinic environment? Well, much of this has been dependent on using body maps to help identify widespreadness of pain. As I demonstrated in a prior lecture, I think yesterday, we developed and validated a Quire body map that's being used extensively. And we've also not only published on it, but we've put some R code, statistics code posted on CRAN that you can download to use for analysis of the body map. All of this is free. This body map is also used extensively within REDCap. And if you're using a body map in REDCap, you're undoubtedly using this body map. So why mention the body map? Well, through an NIH-funded effort led by Dave Williams at the University of Michigan and also Bill Maxner at Duke, they brought together a number of researchers, clinicians, patient advocates, and they broke us up into different working groups to define a diagnostic clustering, a diagnostic calculator, if you will, for these various conditions: chronic fatigue, chronic low back pain, endometriosis. And we all came together in a little working groups and we put together what would be the criteria. I was on the chronic low back pain. I actually had it easy because all we did was take a prior task force I was on from the NIH on the chronic low back pain task force, and we just took the minimal data set from that and plopped it immediately in. And from this, we were able to develop a screener. We've integrated this into Quire. Dave Williams at Michigan has integrated this into a standalone screener, which I believe you can go online and directly use. And it allows you to clinically characterize people and get use research validated tools to determine if somebody meets these individual criteria. So I want to pivot now into this concept of high impact chronic pain. This is, if you will, the twofer of the session. And as I mentioned, we'll show how these all come together in just a few minutes. The notion of high impact chronic pain has its origins back in the Institute of Medicine Relieving Pain in America report that was released in 2011. And you may remember this report. This is the one where we did an econometric study as part of it and found that there's 100 million Americans who live with chronic pain, that we spend in excess of $500 billion a year in direct and indirect medical expenses. It's more than diabetes, heart disease, and cancer combined. That is, by the way, as an additional soundbite, that's based on 2008 data. So these numbers are getting quite old. We have an ongoing study in collaboration with the CDC to reanalyze the MEPS database to get us more up-to-date information on actual costs and numbers. What followed from the I01 pain report was a call to then Secretary of Health and Human Services, Kathleen Sebelius, to put together a strategic plan for the country. That was delayed by a couple of years, but ultimately came together and was brought to the NIH as part of the Interagency Pain Research Coordinating Committee, which I was a founding member of. Chris was also a founding member. Dr. Darnell is currently a member. Forgive me if there's any other members in the audience I'm leaving out, but it's a group that helps oversee or coordinate many of the NIH Institute's efforts around pain. We were asked to put together the first strategic plan for our country around pain. We brought together 81 national experts across all disciplines, clinicians, scientists, policymakers, patients and their advocacy groups. We created 6 working groups that you can see here. I'm going to focus on the population research working group. This is one that Chris was on as a member of this working group. They came up with 3 specific objectives, and it's this first objective that is the one of relevance here: to estimate the prevalence of chronic pain and high impact chronic pain. This is a newly defined term that came out of the National Pain Strategy. We needed a way of characterizing high impact chronic pain. And so we ended up using a screening tool here that you can read here based on these 3 questions. And from this, Michael von Korf, who was one of the co-chairs, the other was Ann Scher, did a small survey study out of group health in the Washington, Seattle area. And of those people in the Seattle area, about 44% of the people had chronic pain and 14% had high impact chronic pain. We published that paper in the Journal of Pain and also operationally defined high impact chronic pain as that pain that is associated with substantial participation restrictions due to pain in work, social, and self-care activities that last 6 months or more. By definition, these are the people that are having a more severe impact to their activities of daily living from chronic pain. These are the types of patients that we see frequently in tertiary referral centers, and probably many of you are seeing in your clinic. We wanted to know what the national prevalence of high impact chronic pain was. And so in collaboration with Chad Helmick, Jim Dahmer at the CDC, we analyzed the NHIS data, the National Health Interview Survey, which is a yearly survey that goes out yearly. And it's, I know. It's where we're characterizing the general health of the population of the United States. Obviously, it's a sampling of that, but from that you can extrapolate to the entire United States population. And we introduced within the NHIS questions around the impact of pain. We got those introduced into it. And from that, we published CDC MMWR in 2018. That showed that 50 million Americans have chronic pain and 20 million Americans, or 8%, have high impact chronic pain. Now, I'll tell you, one of the questions, one of the critiques I get all the time is people saying, Mackey, I don't get it. In one breath, you say there's 100 million Americans with chronic pain. And in the next, you say there's 50 million with chronic pain. Can you make up your mind, please? Which is it? Did, from the time that the IOM pain report came out until the CDC, did you just cure 50 million Americans with chronic pain? The answer is obviously no. So the answer is, which of these numbers is correct? The question is, which of these answers is correct? And the answer is they're both correct, because it depends on the way you ask the question and how you dive into these very large population level administrative databases. And this is one of the challenges that we face, is the quality of the data still remains rather poor. But let us all agree, whether it's 50 million or 100 million, that's a lot of people. That's a lot of people. 20 million with high impact chronic pain. What we learned from this is that these are the factors that either did or didn't play a role. Employment status was a big factor here. If you're unemployed, you're much more likely to have high impact chronic pain. There was a very strong relationship with increasing age and high impact chronic pain. Sex was a difference, but not that much of a difference. It was 8.2% of women who had high impact chronic pain and 6.7% of men, difference of about 1.5%. It was statistically significant when you look at large numbers, and there is a difference. Education was one of the biggest players. If you had less than a college age education, very high likelihood of high impact chronic pain. The veteran status didn't matter. Ethnicity, interestingly, didn't matter. It was pretty flat across the board. Poverty status or income, huge. If you were low income, you are much more likely to have high impact chronic pain. What we've also learned, and this is just starting to come out, that high impact chronic pain is also associated with higher healthcare costs. Now that passes the sanity test for all of us, right? But the reality is we don't have good data on that until recently. This paper out of Spine showed that from a spine care standpoint, that those with high impact chronic pain had medical costs more than double those with still significant but lower impact, much more likely to be on opioids and use 5 times the morphine equivalents. Unpublished data out of our group here, this slide is a representation of all of our patients. The take-home message here is that the more body map areas you have, the more likely you are to have high impact chronic pain. So I'm starting to kind of bring some connection here between them. This one is going to solidify that connection. This is a paper we just published in Science Advances, over 10,000 patients where we did a clustering analysis. This was a pain agnostic clustering. In other words, we took non-pain related symptoms, and from this we did extensive set of machine learning approaches, both at baseline and longitudinally. And what we identified are 3 very distinct symptom severity clusters around chronic pain. Each of these clusters had very high relationship to more pain specific issues, pain interference, pain intensity, but also the body map. The more severity of the pain you had in these clusters, the more body map areas you were likely to have. And so this is where, again, I'm trying to tie together. We want to tie together chronic overlapping pain conditions and high impact chronic pain. I want to pivot now just a moment, still focusing on high impact chronic pain, and help you to see where the science is currently, where the problems are in operationalizing our measurement of high impact chronic pain, and where we're going forward in the future. I like this quote from John Tukey, who's a noted statistical mathematician. It's a mouthful, folks. When the right thing can only be measured poorly, it tends to cause the wrong thing to be measured well. And it is often much worse to have good measurement of the wrong thing, especially when, as is so often the case, the wrong thing will in fact be used as an indicator of the right thing, than to have poor measurement of the right thing. It's a rather deep and insightful comment, but you have to really think about it. And the problem that we often see is we're trying to measure the right thing, but we're often measuring it the wrong way. Let me give you an example of this from a paper that we did a few years ago. We were finding in our clinic, using a learning healthcare system Choir, when we're tracking patients, we would frequently see reductions in pain intensity and pain interference in our patients, but we wouldn't see physical function change. Now, pain interference is really defined as the degree to which pain interferes with some activity, social functioning, physical activity, emotional functioning, sleep. Physical function is what is your capacity to do A, B, and C? How easy can you walk up a flight of stairs, walk around the block? Most of the clinical guidelines, state and national, tell us that we need to measure pain and function. But if you go into those guidelines, the instruments they have you use are getting at pain interference. And the question is pain interference a proxy for physical function? Does it work? Let me just give you the take-home message. It doesn't. It works poorly. This is getting to what Tukey was saying. In most of our guidelines, we're measuring the right thing the wrong way. And so this is going to get to this point about high impact chronic pain and why we need to better operationalize our definition of it, why we need to take a patient-centered approach and measure it the right way. And I'm going to show you just a little bit of a video clip here.
I used the scale you developed to measure my patient.
I'm going to ask you, can you bump up the audio on that just a little bit? This is a cute little animation from Karen Cook, who talks about the challenges we have. If any of you have used patient-reported outcomes and you get numbers associated with it, how is it that you interpret those numbers and make some sense out of it?
I used the scale you developed to measure my patient. She got a score of 35. What does this mean?
A score of 35 is 2 points better than a score of 33 and 2 points worse than a score of 37.
What does this mean?
I am confident that a score of 37 is higher than a score of 35. 2 points higher. Though, of course, that's not taking into account measurement error.
What does a score of 35 tell me about my patient?
I have used modern psychometric methods to develop my scale. If you had used a scale that used a classical test theory approach, you would not have been using the state-of-the-art methods for measuring health outcomes.
Can you tell me what a score of 35 means in the context of my patient?
Modern psychometric methods place both people and items on the same mathematical continuum. This is better than CTT. CTT is how we in the field of psychometrics refer to classical test theory. CTT.
I also used your scale in my research study. My sample had a mean score of 43.2. What does this mean?
There are many item response theory models, IRT models. Some have 2 item parameters and some have only 1 item parameter. I use the best one.
You are of no use to me or to my patients.
I gave a plenary talk at the International Council on Measurement. I think you should know that it was well received.
I want you to go away.
I don't know if any of you have been faced with a situation where you're looking at these scores and you're trying to make some clinical sense out of it. What does it mean? One of the challenges in high impact chronic pain is figuring out both how to measure it and what does it mean? What does it mean for the patient in front of us? Now, the definition that we came up with in the National Pain Strategy, we used a Delphi process, which really meant that, you know, it was Chris and Michael and Ann and a bunch of us sitting around the room, and we're kind of talking with each other and we're narrowing things down, but we kind of made it up. And we came up with this definition, but we recognized that it wasn't particularly patient-centered. And in follow-up studies, this one done by a physical therapy group that was really nice, they identified 10 different attributes that are of high importance to patients, many of which we do not have operationalized into the definition of high impact chronic pain. Meaning that the notion of high impact chronic pain is highly contextualized, and it may be very individual for the person. Dr. Van Korf has followed up with a revision to operationalize this definition. And I'm gonna blast through this one. This is taking his graded chronic pain scale and revising it and coming up with a systematic approach to getting at high impact chronic pain. I put this up here as a reference resource for you if you're interested in this. We're just had a paper accepted where we sat down and talked with people with chronic pain. And what I mean by we is I mean Dr. Yu, who's an instructor in our group on an NIHK grant. And what we wanted to do was find out from their perspective, what are the attributes that are most important to them from the standpoint of pain impact. And we correlated that with the PROMIS pain interference, which gives you a continuum. This gets to that, you know, that number, if you met, you know, you saw in the video, the cute video here. And the 2 take-home messages are the following. We looked, by the way, at age differences, younger and older. And she defined older as older than 65, which is getting closer and closer for me. And younger being younger than that. What we found is the following, that there was no difference in the score, the PROMIS pain interference between the younger and the older. But here's the real punchline, that the items were much different between the younger and the older. That what was important for the younger group were things such as work and physical activities. But what was much more important for the older group were engaging in fun activities, socializing, social activities, and work, and being around friends and family, meaning that what we may have to do moving forward when we operationalize this concept is take into consideration the individual attributes of the person, age, sex, ethnicity, and figure out what is most important in defining impact for them. Very briefly, we received an FDA grant. Chris is on this as well, where we're developing software that's going to allow us to get at this very thing and put cut points along this continuum of pain interference to identify what do these scores actually mean for us as clinicians, to allow us to define what is mild, what is moderate, what is severe and use this for better clinical decision-making. Finally, as we're bringing some closure into this, I come back to the 6 blind men and the elephant and note that it doesn't only apply in the context of chronic overlapping pain conditions, but it applies to the information that we gather as clinicians and scientists. We frequently view data in its isolated manner, whether it be a patient-reported outcome, whether it be a blood test, a sensory test, maybe data from wearables. And where we're going, and this is part of an ongoing grant that a number of people, Beth is on this, Chris is on this, we've got a number of groups on this, is to develop objective biomarkers around high impact chronic pain, where we're going to be capturing quantitative sensory testing, brain imaging, patient-reported outcomes, wearables, multi-omics, building machine learning algorithms. The whole purpose of this is to integrate all of these biomarkers into clinical decision support tools that will allow us to get to that holy grail of precision pain medicine, where we can risk and treatment stratify, identify these people with high impact chronic pain, chronic overlapping pain conditions, and get them on the appropriate pathway. Back to you, Chris.
So we've heard about all these really swift initiatives and cool studies that are going on at Stanford and other places. And at the end of the day, what does it all mean for patients, right? Like, all of this stuff is going to be able to help us better care for patients in the future, kind of not there yet, but we also have this patient population right now that we need to care for. So what do we do? And I just put this slide in here just to say that, you know, this is the end goal, right? With my own personal story, like I said, I've had chronic pain for 30 years. At the worst of it, it took me 6 years seeing 6 different clinicians, all of which I was managing on my own, tried over 20 different non-pharmacologic and pharmacologic therapies, some of which are listed on this slide, spent 20 to 25 hours per week engaged in therapies, and tens of thousands of dollars to try to find what works for me. Right now, we don't know what works for whom, at what cost, at what risk, and in which care model. So we have this whole kind of cadre of therapies that are available, which is great. But how do we get to a point where we have precision medicine type of data that Sean is talking about to really be able to develop treatment algorithms? And when patients come into the office, be able to say, well, based on X, Y, and Z, these are the therapies that are going to be most helpful to you, we think, right? Rather than just going through this long trial and error process. But from the patient-centered perspective, in the interim, what I would pose to you as clinicians is there are 2 really important things that you can do, right? As you're working with patients to try to identify which therapies are helpful to them, it's really important to shift from an illness model to a wellness model, right? And one of the very frustrating things, and I didn't put my wellness model slide up here, but one of the very frustrating things about pain care, and it's to no discredit by any clinician, this is just the way we measure it, is when you go on, they say, how bad is your pain in the last month from 0 to 10? All right, well, I put down a number, I try to think of what it is. I don't know because it's variable on a day-to-day, hour-to-hour basis. And what does that really mean, right? And you're asking your patients, how bad is it? I would pose to you to turn the question around and say, what can we do to make it better, right? Even though you may have a similar number on a pain scale, what can we do to actually make your life better and make your life more well? And one of the really useful tools is setting functional goals with your patients. And as Sean mentioned from one of his studies, this can be very dependent upon age and also all types of other factors. What may be important to a 20-year-old who has, a certain isolated pain condition versus an 80-year-old may be different. And it's not just, again, age dependent. But what are functional goals? So it's individually meaningful activities that a person cannot perform as a result of illness, but wants to be able to accomplish as a result of pain management. So let's shift the conversation from saying, okay, how bad is it? How bad's your sleep? How bad's your mood? To what do you want to be able to accomplish with pain care? And obviously these have to be realistic goals. It can't be, I want to run a marathon in 2 months, right? But there are systems that are in place. And I invite you to, if you're not familiar with this, there's a link at the bottom of the screen that actually gives you kind of a clinical worksheet that you can use with your patients. But research really demonstrates that goal setting with your patients increases progress towards mutually agreed upon goals. It fosters adherence to recommendations that you're making. It helps create successful individualized treatment plan, and it really improves the patient-clinician communication. And there are steps that you can go through. The first is really to address faulty beliefs, like movement is going to make my pain worse, right? There's a lot of different faulty beliefs that people with pain develop over time as a result of what we experience. But it's really important to address those first off, and then to select a focus area. Do you want to engage in more social activities? Is it an act, or do you want to be more active? Do you want to be able to walk, or whatever the goal may be for that particular person? There's a SMART system that's in place to set goals that are specific, measurable, actionable, realistic. To break that goal down, maybe your goal is to, within 2 months, I want to be able to go for a 1-mile walk. Well, that's really overwhelming to somebody that has chronic overlapping pain conditions on day 1. So how do we break that down into week 1, week 2, week 3, and set actionable goals that are actually realistic? And then ahead of time, really to identify obstacles. What if it's raining? What if I don't feel well that day or whatever? And what the patient is going to do in that situation to come up with solutions to keep them on track. And the other area is really about shared decision-making, so switching from I'm the clinician, this is what you need to do to the patient, right? But then also, shifting that in a way where you're actually putting the patient in charge of his or her own care. And giving them an active voice, right? You can make recommendations, but you also need to listen to what's important to them and come to an agreement together on what's important in the person's care. So the first step is seeking patients' participation. You want to make them an active participant in their care, right? Not just a passive recipient of the care. Help them to explore and compare treatment options, to assess their individual values and preferences, to reach a decision together, and then evaluate the decision over time. And there's, again, a resource at the bottom if you're not familiar and want to learn more about this. And then I just wanted to mention that we as an organization have developed a number of resources that are available on overlapping conditions. We have a companion patient self-help book that goes through a lot of what we cover. We have a CME, a brochure that's available for patients. And we also developed a white paper, which really lays out the scientific foundation for the overlap of these conditions. It's not just an idea that we came up with, but there's actually evidence that shows the relationship among these things. And of course, feel free to visit our website. And I think that's it for us, and we can take questions.
And we have time for questions, please. Yell it out.
Okay. Oh, I was just saying, functional medicine, different how we use functional medicine here tends to be very separate from conventional medicine. And I don't know if you see in your work at, the different levels, is there a place at the table for functional medicine? Is that already happening? Is that an appropriate role? I'd love to get your perspective. Give us a little detail on what you're. So functional medicine now has different organizations, international functional medicine, different training programs that look at a biopsychosocial systems approach, definitely not breaking it down into a particular discipline, looking at genetics, environmental exposures, nutrition, supplements, nutraceuticals, diet, the whole role of trauma, the sympathetic response. There's a organized training in that role. In my experience, most people that are getting trained in it get outside then the conventional system, insurance system, gets very hard to navigate, but it's a paradigm where I've seen most of my patients get some benefit. So I'm just curious whether that has any presence in some of the work you're doing with all the other stakeholders at the table.
Yeah, in that can. Oh, no, I'll get back up here. I was just going to walk it around just to try to be helpful. Within the context of that, there's kind of this integrated approach, right? And I think very clearly a team-based integrated approach seems to be showing the best benefits. And that's building on some of the basic tenets of multidisciplinary care that we've known for decades. And one concept, it's expanding it beyond the traditional physicians, psychologists, physical therapists, nurses, pharmacologists. Forgive me if I'm leaving a specialty out, but getting in the nutraceuticals, the food microbiome, and those other aspects. I can't tell you if that whole package has been studied in the context of either high impact chronic pain or chronic overlapping pain condition, but one would presume that, you know, it passes a basic sanity test, that it should have a positive impact. And it sounds like in your practice, you've seen such. You know, Chris, have you heard much in the way of those aspects?
I mean, I don't think that it's particularly being studied, if that's your question, but certainly just based on the whole multi-domain approach that we're talking about, it's a more integrated, team-based, holistic measure, right, towards assessing what's going on in the whole person rather than just an isolated part of the body or symptoms.
Yeah. NCCIH looks at pieces of that. National Center for Integrated Health looks at aspects of that from the nutraceutical aspects and other health-related portions. I don't know, pardon me, if they put it together from a full team-based standpoint. We integrate nutraceuticals in our system. We've got within Epic dot phrases for a number of these nutraceuticals. Have I ever gotten a huge win with them? Probably not, but I get small wins. And what we're looking for is building on incremental wins and packaging all these incremental wins to make a bigger win. I know it's a little long-winded response, but clearly we need more research in this area. Let's go over here.
Thanks. That was great. Awesome. So, you know, the role of underlying psych trauma, you know, was just perfect for this. And I've seen estimates anywhere from 20 to above 50%. It you know, really, there's no consensus in that regard. But pain that maps out to multiple sites or is overlapping with other conditions or maps to head or abdomen or pelvis, you know, just seems to be a stronger association with psych trauma. And, you know, you mentioned patient-clinician communication, and that seems to be one area where it's very challenging, especially if one's attempting to discuss, you know, for both clinician and for patient, to discuss violation of physical boundaries as childhood events, adverse childhood events. But, you know, it certainly seems to be critical that if that component is not addressed, and you talked about the biopsychosocial spiritual, you know, approach there, that first off, so two questions is what has been your observation of underlying adverse childhood events that was mentioned? I don't know if you have any data on that, and whether or not you can look at mapping and get stronger correlations depending on the mapping, and then also, you know, the somatic mapping. And then secondly, is could you possibly use any of your products to facilitate that conversation, because it would be critical, and it is so awkward and difficult for the majority of clinicians and patients.
You want to take the second? I'll take the first. So from the first, you know, really spot on questions. And there's so much to unpack there that I'll try to be brief. The issue is getting at causality, right? When it comes to adverse child events, the only way to do that is to really look at things longitudinally. And there are a number of studies in which there are longitudinal characterization of patients. UK Biobank, others are doing these national long-term studies to follow people through to establish a causal relationship. So what we're showing here, what I showed in what we did, is cross-sectional data. So there's an association there, but we don't know chicken and egg, you know, aspect. We can all hypothesize. It shouldn't stop us from treating it, by the way. No downside. With regard to the therapies in that regard, that's an interesting area that I think is getting more and more interest. Mark Lumley has been spending a fair amount of time looking at trauma-related aspects. Our own Mesa Siadny, working with Beth Darnell. Beth is primary mentor for her. Beth has created this intervention empowered relief. It's a brief one. Mesa is creating a brief intervention in the intersection between pain and trauma. Beth, do you have anything you want to throw out on that aspect? Yeah, I mean, traditional CBT Act and all that, from my understanding, doesn't really get at the heart of that. Mesa and others are getting into this more trauma-related therapy aspect. So yes, we need to understand the causal mechanisms. We need to identify what are ultimately modifiable and non-modifiable factors. Non-modifiable factors meaning, well, height, sex, we can't change that. Modifiable factors, maybe underlying anxiety, catastrophizing, beliefs, cognitions that we can modify in a therapeutic relationship, which now gets to Chris and your second question.
Yeah, I would just say this is a really sensitive topic, especially for people who have pain, and mainly because many, and I particularly work in the realm of women, have been undiagnosed, misdiagnosed, told it's all psychological, so on and so forth. And many of the diagnoses for pain are rule out. If you don't have inflammation, if you don't have cancer, if you don't have this virus, if you don't have this, then you have pain in this area of the body, right? So but we don't know what the underlying mechanism is, right, at this point in time. So it's a very, very sensitive topic. And what I would say, and we review this in our white paper as well, it's not just pain that's been linked to that. Many chronic diseases actually have this linkage. And what Sean is saying, I would completely agree. Association doesn't mean causation, but it plays an important role. And I would say language really matters, right? And you do need to, I can understand it's an awkward topic, it's a sensitive topic, but I think when you introduce pain neuroeducation first, and you explain and educate people about how the role of the brain and the body systems and the biopsychosocial spiritual makeup of pain plays an important role in how you experience pain, both what you've experienced in the past and in your current situation. It helps ground people to understand where you're coming from. The question is, why are you asking this question? Are you asking it because you're trying to find a reason for why I have pain now because you don't necessarily believe that I have pain? That's where it comes from. So if you can educate patients about the complexity of pain, and the fact that we really need to understand all and identify all of the biopsychosocial, spiritual domains that play a role in your individual experience, and then have that conversation from there, people are much more receptive to the psychological and traumatic issues than they are if they just say, hey, were you abused as a child? And you're sitting there saying, oh, great, here's another doctor that's just telling me my pain is psychological and it's not real.
Well, see, specifically though, you have great products, and the mapping is really easy. And my question was, how might you integrate that? That kind of identification into your product so that it takes the burden off the clinician. I'm comfortable doing it, but I've also spent years.
Yeah, and I see that I may not have answered your question. So let me just take another stab at this. If you're asking about how to put this into a clinical tool. So what we've done, and again, it's the learning healthcare system we've developed in Choir actually gets at adverse child events. We ask that. If you live in the state of California, by the way, you're actually paid money to ask those questions to your patients. There is a reimbursable code for it in California. Not a lot, but it's an incentive. So we ask those ACEs questions. We do ask about other trauma-related questions, PTSD-related symptomatology, other both child and adult-related adverse events. We flag those, and we also get a number of other symptoms such as anger, depression, anxiety, catastrophizing, sleep. Now, getting on to what Chris said is, how do we use these tools? Well, it's exactly what she said. It's building a rapport with the patient. So it's getting a trust, it's validating them. And then it's a degree in our end of motivational interviewing as physicians. We start picking off the easy stuff. I see your sleep is terrible. your sleep score here is a 65, you're 1.5, you're at like the 85th percentile of sleep. Your sleep really sucks. At least by the scores. Does your sleep, is it that bad? Yeah, my sleep is terrible. That's an easy entry because everybody's sleep's terrible. And we work on helping them with the sleep, and then we'll move into things like fatigue, and then it'll be depression and anxiety with the scores that we have. And it's kind of gaining some degree of trust that we're not immediately going to the heavy stuff. And then we'll work our way into the more sensitive things with those scores. And back and forth, it's asking, do you want to do anything about this? And so that's how we approach it. A lot of this is, though, you're trying to enable trust and rapport first. It sounds like that's a thing you already have down. You're looking for the other tools.
Yeah, I'm just looking for the other clinicians because I've spent a lot of time, like there's a lot of trauma there, a lot of time we had groups.
Yeah.
I've heard a lot of trauma stories, so I'm very comfortable with it, but most of my colleagues are not. So I'm looking for a way to support the other workforce. And also the patients too.
Yeah, I think, you want to look at the work that Mesa is doing in crafting this trauma-related pain intervention. I've actually gone through her training session. It's really quite cool. It's got some great languaging around this. It is pain-focused, by the way, but if you want to make a connection afterwards for you, I think she'd be interested in chatting with you.
Yes.
And it's based on some really good research, a number of publications. Thank you. And that, any other questions? I'm mindful of the fact that we're over. We're again on the last. Oh, you're giving us like a. Yeah. Okay. If there's somebody else who's supposed to start, come on up. Don't let us hold you up here.